68-year-aged male, Hindu, farmer by occupation, resident of Jaunpur, UP, presented with the chief complaints of ulcerative lesion over the right cheek for last 15 years. Patient was apparently normal 15 years back when he noticed a small ulcer over the right cheek, approximately 5 millimeter in size, which increases very slowly over the last in the size over the last 15 years. But for the last 6 months, ulcer has grown rapidly to the present size. There is a history of purulent discharge from the ulcer for the last 1 month. There is no history of any associated pain or itching. There is no history of similar lesion elsewhere in the body. There is no history of trauma, no history of cough or breathlessness, no history of headache, vomiting, loss of weight, appetite, or any history of bone pain. There is no similar history in the lesion in the past. There is no history of previous surgery or radiation. There is no known comorbidity like diabetes mellitus, hypertension, coronary disease, tuberculosis. On personal history, patient has a history of chewing tobacco for more than 40 years. Patient is taking a mixed diet. There is no similar complaints in the family members. There is no history of malignancy in the family members. On general examination, patient is well oriented in time, place, and person. Of ECOG status 1, average build and nutrition. There is no parallel cyanosis, icterus, clubbing, edema, or generalized lymphadenopathy. Neck nodes, including supraclavicular nodes, are not enlarged. On local examination inspection, a 6 to 5 centimeter ulcerative lesion noted on the right cheek involving the right commissure. It is irregular in shape. Edges are raised and beaded with black pigmentation. Floor is covered with pale granulation tissue and slough, and purulent discharge noted at the center of the ulcer. Surrounding area outside the raised black edges are normal except on the superior and posterior aspect where there is another raised edge with black pigmentation with intervening erythematous skin in between. On palpation, ulcer is non-tender with irregular margins. Edges are raised and beaded. Base of ulcer is indurated. It does not bleed on touch, and skin around the ulcer is normal. Inside the oral cavity, the right buccal mucosa was normal. Other system examinations were normal. Summary: a 68-year-aged male, farmer by occupation, with ulcerative lesion in the right cheek, which is increasing very slowly for the last 15 years, with rapid increase in the size for last 6 months. On examination, a 6 into 5 centimeter irregular non-tender ulcerative lesion with raised edges and black pigmentation, with purulent discharge in the center of the ulcer. Floor is covered with pale granulation tissue and slough with indurated base. The skin surrounding the ulcer was normal. There was no cervical lymphadenopathy. So my working diagnosis is malignant skin lesion.
Okay, which of the skin lesions?
Will you just say malignant skin lesion? Is it giving you some indication of the type of lesion it is?
Yes, ma'am. According to the examination, the ulcers, the edges of the ulcers are raised, beaded. It suggests of basal cell. More of likely in the diagnosis of basal cell carcinoma.
It is actually quite pathognomic. Show us the clinical picture.
Yes, ma'am. Yes, ma'am. It is basal cell carcinoma.
What other diagnosis could it be?
One other finding is, ma'am, field fire appearance in which there is.
So that is only a presentation type of BCC.
Yes.
The basic pathology is the same.
Why it is important, Sandeep, to have a clinical diagnosis that it is a pigmented BCC and not a melanoma?
Differentiate. Tell us the differences, starting from the history. Why it's not a melanoma?
Yes, ma'am. In the melanoma, ma'am, there are different. The melanoma, there is A, B, C, D, E. A for asymmetry, B for irregular border, C for color changes, which is not there.
Oh, this AB, excuse me, this ABCDE is for a nevi, if it existed. And it shows changes over a period of time.
Yes, ma'am.
Did he have any nevus?
No, ma'am. He didn't have any nevus. First, ma'am, there is no color changes, which is quite common in the melanoma. Also, the the evolution of the
could be amelanotic melanoma. So that's not a difference.
And this is a pigmented lesion. So why do you say it is not a melanoma? So what is the difference between an ulcer of a melanoma and an ulcer of a BCC?
Yes, sir.
That is the question of Dr. Mallika.
Yes, sir. The ulcer of BCC has the raised, everted, and beaded appearance, while the melanoma doesn't have these features. Also, the ulcer of the has deep burrows, which doesn't have in the melanoma. Along with that, the color changes might not be there in both. And
What is a rodent ulcer?
rodent ulcer is typical of the basal cell carcinoma, in which the ulcer is burrowing deeply, like burrowing deeply inside the skin. It is typical of.
How do you illustrate it in your clinical examination?
Sir,
And we are not done with the differences, mind you.
burrowing is shown by taking a sterile swab stick and inserting it inside the ulcer edge, and getting how deep it is going inside the skin edge.
So the edges are overhanging.
Yes,
What did you say your edges are?
we did.
So how can it be BCC? You can see it is clearly visible overhanging, especially on the upper side.
Yes, sir. Overhanging. Overhanging.
But you have not demonstrated it. You say the edges are everted. So in which ulcers the edges are everted?
No, there is a difference between everted edges and beaded edges. It is quite there in ESDAS, if I'm not wrong.
So this is classical overhanging edges.
Zoom
The
karo.
ulcer is actually
हाँ.
no, he won't be able to demonstrate because he has to have a stellate or a swab to go under the skin and show that the skin is overhanging over the ulcer. He has not demonstrated that. If you go on the 12 o'clock under the skin, you will be able to go up to that black line on the top. So this much of the skin is overhanging over the ulcer.
So
Why
where
it
is the margin? Move your cursor on the margin.
Yes, ma'am. This is the margin of the ulcer, superior margin. This is superior margin. This is the anterior margin, which is involving the commissure and the lower lip. This is the inferior margin. This is the inferior margin. This is the posterior margin.
So from 9 o'clock to 2 o'clock, you see the skin overhanging the ulcer. Why it is important to know a clinical suspicion of a BCC versus a melanoma?
Because the lymph node metastasis is very common in the melanoma, but in BCC is very less.
Your workup is going to change. Your workup for melanoma is different from that of a BCC. So that is why it is important to clinically differentiate a pigmented BCC from a melanoma.
Where does this BCC arise from? Which layer of the skin?
Basal layer of the epidermis, ma'am.
Which layer of the epidermis?
Basal layer, ma'am. Basal layer of the epidermis.
Okay, so what will you do next? You have a diagnosis of malignant skin ulcer. So what will be your next step?
There is no orocutaneous fistula here.
No, so oral cavity was normal.
In the investigation, I'll do a edge wedge incision biopsy. I would like
Can
to
you
go
put your cursor? Can you put your cursor on the ulcer and tell me from where the biopsy you will take?
Yes.
Which area you are going to biopsy?
I'll take a biopsy from this area, which is I can take area which is the active lesion. I can take area biopsy from this lesion, or I can take from this.
What kind of biopsy will you do in this?
Edge wedge incision biopsy, sir.
Why don't you want to do an excision biopsy in this?
Sir, the mass is very big, sir. I need to know if the biopsy comes under because the size is the size is very big. Second, if I'm considering if I'm thinking of basal cell carcinoma, I'll have to differentiate it from the localized low risk or high risk, because in both the margins are different.
Okay.
So biopsy, what else?
The edge wedge incision. I would like to go for blood investigation, X-ray and ECG, and I would also like to go for CCT face and neck, because this lesion is very.
Why CT? Why CT?
Yes, sir. Yes, ma'am. Because there is long history of the lesion with sudden increase in the size for last 6 months. First reason. Second is, ma'am, the BCC is known for underlying bone involvement. So the lesion is in the area of the mandible, and the base is indurated, so we cannot differentiate whether it is involving the bone or not. So I would like to go for a CCT.
Was the lesion fixed to the mandible clinically?
Ma'am,
or you could move it with the skin?
I could actually, my mobility was little restricted. mobility was little restricted because of induration. I could not move it very freely as we can do in
What is the base of this ulcer?
case of the ulcer is that most likely subcutaneous tissue. It is not bone, but I'm not quite sure because I'm
It's
not.
definitely not bone. You are in the region of the cheek, right? What I'm trying to say is, I mean, is it the mucosa? What is the flow? What is the base of this ulcer?
So ulcer is the cheek. In the cheek, it is mucosa, but in the downside, in the lower side, it could be sir. It could be involving the mandible. Could be
Okay. So you justify CCT face. Why neck?
the neck. Sir, although the lymph.
No, sir. One more thing. Will you wait for the biopsy to come before you order any kind of imaging? Can your imaging change based on the biopsy report you get?
His question is your imaging going to change by the type of the histological type of the lesion?
Yes, sir. Yes, sir. Yes, sir. It might change because if in the histology there is perineural invasion, then I'll go for MRI. If there is no perineural invasion, I'll go for CCT. On clinical suspicion whether it is involving bone or not, I'll go for CCT test.
I
So
still
why-
didn't get it. You please explain why PNI will lead to doing an MRI here?
Ma'am, if the biopsy sensitive of perineural invasion, then the guideline says ki MRI of the region should be done because because in the MRI we can say it, which nerve involvement, because if the nerve involvement is more than 0.1 mm, the thickness of the nerve is more than 0.1 mm, then we have to take an extra margin.
You tell us how is MRI better than CT face in this situation? How is it going to help you to change your management? Is it going to do that or no?
Sir, in this case, it is not going to change my management because
So then why do you want it? Irrespective of perineal invasion or no perineal invasion.
So why neck?
Why BCC doesn't produce lymph node metastasis in
yes,
large
ma'am. Because
majority?
yes, ma'am.
Why?
BCC in BCC, ma'am, the tumor cells block the lymphatic channels early in the disease course, so that doesn't produce lymph node mates. And also the BCC is dependent on the surrounding stroma for its development. So it is very less likely to develop distant metastasis because of dependence on the surrounding stroma.
So in a N0 neck, you don't need to do an XCT. Will you address the neck here or not?
Actually, sir, yes, sir. I should have written only the CCT face, not neck.
So you got your biopsy?
Yes, sir.
What is
Biopsy came as infiltrative basal cell carcinoma, and the CCT face shows 5.8 into 4.8 into 1 centimeter heterogeneous enhancing soft tissue lesion involving the skin and subcutaneous tissue over the right cheek. There is no bony erosion and there is no cervical lymphadenoma.
So no surprises here. Huh? So what is your plan of management now?
So the final diagnosis will be high risk basal cell carcinoma. So so the best option for this patient will be more micrographic surgery with followed by uh, uh, followed by a graft, either a free macrovascular graft. But since MMS is not available in our, sometimes it is not available. So I'll go for surgical excision with a margin of 5 to 10 mm, followed by free microvascular graft, most likely a radial forearm free flap.
You will be excising the mucosa or leaving the mucosa?
The deep margin, I won't get 1 centimeter of the deep margin, so I will be taking the mucosa with the specimen.
In BCC, is a margin of 1 centimeter really required?
Ma'am, actually, the paper, one paper is by Gitelli, which shows in the patient of low risk of basal cell carcinoma, the 4 mm margin is enough. But for the high risk BCC, high risk basal cell carcinoma, localized basal cell carcinoma, the best option for that patient is more micrographic surgery. But if it is not available, the margin should be extended. And in Ma'am, Devita has written at the margin of 5 to 10 mm, but NCCN has not specified any margin. It has written wide margin. It has written only the wide margin.
And what is this risk stratification? Tell me.
So
Yes, sir.
what is the biggest dimension of your tumor? You tell the risk stratification first.
Yes, sir. Yes, sir. The risk stratification is first the site. Any site over the sites like lips, nose, periorbital skin, chin, and periauricular skin. A tumor of any size in these areas comes under high risk. Second, any tumor of size more than 1 centimeter in the face, in the forehead, scalp, neck, and the temple area. Sorry, in the cheek comes under high risk category. Any tumor of size more than 2 centimeter anywhere in the body comes under the high risk category. Next, any recurrent tumor comes under the high risk category. Any tumor following post radiation therapy comes under the high risk category. A tumor with irregular margins. Tumor with irregular margins comes under the high risk category. Any tumor with PNI, perineural invasion, comes under the high risk category. Apart from these, all other tumors are considered as low risk basal cell carcinoma, and these are the
So what will be the size of your defect?
sorry, sir, size of
Defect.
defect will be, sir, almost 8 into 7 centimeter. 8 into
Full
7
thickness. Full thickness.
Sir, it will be full thickness, sir. Full thickness.
So the flap will be required,
Yes, sir.
will be about 16 centimeter. It's a full thickness defect, no? 16 by 14. So are you going to get a radial forearm?
Not that much defect. Not that much radial forearm. I won't get that much defect. I can do for, sir.
No, you planned it. That's why I'm asking.
Actually, sir, the defect, the full thickness defect won't be that big because, sir, in the periphery, where ulcer is not that deep. So the defect might be little. The full thickness defect might be low inside, and the outside skin will be bigger.
So how will you know intraoperatively or before the surgery that how much of the full thickness you have to excise?
From the CT scan, sir, I can.
So what does your CT scan tells you? What will be the mucosal defect and what will be the skin defect?
Mucosal skin defect will be, sir, 8 into 8.
8 into 7 centimeter.
8 into
Fine.
7 centimeter, yes, sir.
How
And
much will mucosal defect?
yes, the mucosal defect will be, sir, 4 into 2 into 2, 2 into 3 centimeters, sir.
And you will lose your commissure.
Yes, sir. Commissure will also.
So your commissure excision will be full thickness.
No, sir. Commissure excision won't be full thickness because it is. I have not taken that photograph, but it is involving just the. It is involving the skin of the commissure, not the mucosa of the commissure.
See, basal cell is going to involve only skin.
Yes, sir.
What about the 1 centimeter depth that you have to take? What is the average thickness of commissure? What is the average thickness of buccal mucosa or the cheek from skin to mucosa?
The average thickness of the buccal mucosa is, sir, almost 1 to 1.5 centimeters.
So how are you going to get a 10 mm margin on deeper margin?
So we might need sir post-op RT in this case.
You are going to create a bigger defect. You need a bigger flap, not a post-op RT. Why do you want to compromise on your margin? You can always do a ALT.
Yes.
Why do you want to compromise your margin?
No, sir. Yes, sir.
As a surgical oncologist, you should not think in terms of compromising your margin.
I get the point. Yes, sir. It should be ALT flap.
Yeah, you should change your reconstruction option rather than trying to conserve and close the mucosa primarily.
Yes.
Because otherwise it's going to recur or you are going to require adjuvant. If you have a full thickness excision, you are not going to require a adjuvant if your margins are clear of 1.5 millimeter or 10 millimeter margins. You can avoid radiation. Okay. What else is planned for this patient?
What is the concept of this Mohs micrographic surgery? The concept behind it?
Yes, ma'am. The concept of Mohs micrographic surgery is the surgeon who is doing more micrographic surgery should use a scalpel knife, preferably preferably the razor blade. If it is not available, then he can use the 11 number 15 number knife first. Second, it is the margin should be the margin of the tumor is taken just the margin the tumor is cut at tangentially just above taking the just normal skin, and it is
I am not asking you the procedure. I am asking you the concept.
the concept behind it is, ma'am, if we see the we take the margin, we see it in intraoperatively, we see the margin status. If it is positive, we can take another 1 to 2
So how it is?
in the microscope, ma'am, in the microscope only.
So you resect and check. You resect and check. Why is it helpful?
Because it conserves the because it conserves the critical areas of the face. Critical
So
areas,
it is relevant only in the areas where
cosmetic
margin.
disfigurement.
Yeah, you don't have liberty with extended margin.